Hi, everyone. We'll give it just a minute before we get started for folks to get into the webinar, and then I will get started. Okay, I will share my screen so that we can get started. Let's see here. Okay. All right, Brenton, jump in if I'm having any visual or audio issues. All right, welcome everyone. We will get started because it is 1 o'clock. So thanks all for joining the 4th day of the Syphilis Virtual Learning Series. Today we're covering congenital syphilis and syphilis in pregnancy, and also some topics that are relevant to the work of congenital syphilis and syphilis in pregnancy. I'm Carmen Dittman. I use she, her pronouns, and I'm the syphilis prevention coordinator at the Minnesota Department of Health. Thanks for joining us. Before we get started, I wanted to cover our land acknowledgement, so I'm just going to read the slide. Every community owes its existence and vitality to generations from around the world who contribute their hopes, dreams, and energy to making the history that led to this moment. Some were brought here against their will, some were drawn to leave their distant homes in hope of a better life, and some have lived on this land for more generations than can be counted. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We are standing on the ancestral lands of the Dakota people. We want to acknowledge the Dakota, the Ojibwe, the Ho-Chunk, and the other nations of people who also called this place home. We pay respects to their elders, past and present. Please take a moment to consider the treaties made by the tribal nations that entitle non-native people to live and work on traditional native lands. Consider that many legacies of violence, displacement, migration, and settlement that bring us together here today. Please join us in uncovering such truths at any and all public events. So we at MDH like to do the land acknowledgement, but I know that not all of you are in the region where the main building of MDH is headquartered on Dakota land. So I encourage you to research what ancestral lands you are living, working, and playing on. So just some housekeeping before we get started. There is a Q&A box on your screen that usually shows up on the bottom margin. Please use that box to ask any questions that you have during the presentation. We will cover them after the presenter is done with their entire presentation, and I will field those questions. So please feel free to ask those questions in there. We also have a chat box if you would like to make additional comments, but we do appreciate when the questions are asked in the Q&A box where everyone is able to see them. For future use, we are recording these sessions so that they can be used in an educational manner in the future. And then we also have our post-series evaluation that we ask that you fill out. This information is helpful to us so that when we put on future educational events, we're able to work off of that feedback. So when you exit out of Zoom or the meeting is closed, the link for the evaluation will show up and you can complete it there, or we will also email out a post-series evaluation for you to fill out. So if you have time right after, that'd be great, but also there's an email option as well. And it typically takes about 5 minutes to complete the evaluation. So with that, I'm going to stop sharing my screen and see, okay. So it looks like Dr. Contag is our first presenter, but he did let me know he is with a patient right now. So we're actually going to jump ahead to Dr. Foster, cover her information, and then hopefully by then Dr. Contag. So sorry for any confusion that may cause, but we do think that it will work together seamlessly either way. So with that, I'm going to hand it over to you, Dr. Foster.
Thank you, Carmen. All right. And seeing the right screen here?
Yep, we see your presentation.
All right, great. Hi, so I'm Jill Foster. I'm the Division Director of Pediatric Infectious Diseases at the U. I also work at mHealth Fairview Masonic Children's Hospital. I'm a recent transplant to Minnesota. I've been here for 2 years. Before that, for the majority of my career, I was in Philadelphia at Drexel University and ran the pediatric and adolescent HIV program there. So where are we going today? So I want to try to gain some insights into the changing epidemiology of congenital syphilis specifically. I know you spent a lot of time on epidemiology of syphilis in general. I want to talk about the impact of syphilis on the fetus and newborn, focusing more on the newborn. I thought that when I was giving this, we would have already just heard the whole lecture on pregnancy, and we build on that, but I'm sure we can all manage through that. I want to outline a diagnostic strategy for the newborn, describe treatment options for congenital syphilis, and I'm going to do this through a series of cases where we're going to talk about diagnosis and treatment together within the cases. And then I'm going to spend just a little bit of time on imagining public health interventions to prevent congenital syphilis. All right, so first the epi portion. So this is my experience taking care of syphilis. People called me and said, well, we need somebody who's an expert on congenital syphilis. And I said, oh my goodness, I haven't done that in a really, really long time until again recently. So back in 1990, I was at this hospital in North Philadelphia, Temple University Hospital, and we had about 1 to 2 patients a day in the newborn nursery who required spinal taps for suspected congenital syphilis. And it was really, really just an incredible epidemic of syphilis, and didn't really know that at that point, I was actually at the peak of syphilis of what we've had for, over many, many years. We were really at the highest national rates and had a national rate at that point of congenital syphilis of 107 per 100,000 live births. And then it kind of went away for a lot of different reasons. But ended up having, now it's starting to creep back again. And I had moved on to HIV, and certainly we had a lot of patients with syphilis with HIV and took care of infants with both HIV and syphilis, but really thought that this was, it was only became recently when I was doing some work out in Arizona to really hear about how bad syphilis has become as a national problem. And this is on the website, the website for the Department of Health in Arizona, that the situation has become so bad there that they actually had to create a dashboard showing that since 2015, the yearly average of syphilis cases in women has increased 449%. The number of syphilis is doubling each year. They have this picture here in the middle of the number of babies that have died with congenital syphilis. And again, I'm looking at these numbers and I'm having a little bit of PTSD of remembering my time back at Temple Hospital when we had similar numbers to this. It wasn't at all unusual to have a baby in the NICU with congenital syphilis. It wasn't unusual to have stillborn babies with congenital syphilis. And had not really realized that it had gotten so much worse, because it was one of those things we thought had gone better. And this is also something that got worse before the pandemic. So it's actually a health issue that we can't blame on the pandemic. So many of them we can. So what's the situation in Minnesota? So congenital syphilis in Minnesota was nicely written up in Open Forum Infectious Disease by colleagues here from the Minnesota Health Department. Looking between 2016 and 2020, there were 47 congenital syphilis cases in 45 moms, which was, as you could see from the graph below, back in 2010, very few or none, and then around 2015 started inching up and pretty high number in 2019. So it peaked in 2020, at a rate of 3.2 per 10,000, still lower than that number I quoted from the last slide. 43 of these cases had congenital syphilis, had no clinical signs. And those are the ones that, I mean, the ones that are horribly affected are ones that, certainly we worry about, but I really worry about the ones that have no clinical signs at birth, because then it gives people an idea of, hey, this is no big deal. 2.1% or one case was inadequately treated, which, a goal would always be that we don't miss any. We have these babies in a hospital, and can intervene. And so we really want to make sure that we intervene appropriately. And there were 2 deaths, which again, unnecessary deaths. So why now? So looking first at the graph on the right, it was not that so women used to be at the bottom. So women are this sort of darker blackish gray here. And back in 2016, there were very few women having syphilis. They were certainly below the population of men having syphilis. And then you could see it went up a little, 2017, 2018, 2019. And then in 2020, women became number 2 after men who have sex with men of syphilis. So if there's more women with syphilis, there's going to be more babies with syphilis. And so in Chicago, they tried doing a little bit of a deeper dive and found that 11% of the 160 women with syphilis diagnosis and pregnancy there had babies with congenital syphilis. So 1 out of 10 women with syphilis with baby with congenital syphilis. So then they wanted to say, well, what are the risk factors of this? Where are the places that we could potentially intervene? What are the things that are kind of the picture of this? And they found number 1, the 5-fold increased odds was with patients with psychiatric illness. And interestingly, non-injection substance abuse. So those were the ones that if you can intervene with women with their psychiatric illness, or even better, reduce the amount of women with psychiatric illness, that's a potential place of intervention. 3-fold rise in women with homelessness in the previous 12 months, and a greater than 2-fold rise in women with late or scant prenatal care, and women who initiated treatment nearly 3 months later in pregnancy. So these are women that are falling through the cracks. And I know you had really good talks on sociocultural determinants of health with this, and these are all the sociocultural determinants of health. These are the places, the cracks in the fabric of our society that women fall through, the women fall through, and the babies fall through. Interesting, at least in the Chicago look, none were human deficiency virus positive or reported incarceration. None had intravenous substance use, sex work, or having sex with men who had sex with men. When we were looking at the group of folks in Arizona, when I was out doing work there, outbreak there was really felt to be very much more related to injection drug use and sex work. So this is a Chicago portrait, and it's not that we shouldn't be intervening and looking in the women with HIV or these other issues, but at least in the Chicago experience, it was psychiatric illness, homelessness, and inadequate prenatal care. So let's look a little bit of what is the impact of syphilis on a fetus. So the picture up there, that's a picture of a spirochete, the Treponema pallidum, kind of looks like a little bit like a snake. I'll come back to that. So the pathogenesis in the fetus is, here's the fetus attached to a placenta. And that there's 2 different ways the fetus can be exposed to syphilis. One is transplacentally, through acquisition through the bloodstream. So the woman has a spirochetemia, and then it passes through the placenta into the fetus. The other way is ascending from the birth canal, that if there's lesions in the vagina, there can be spread to the fetus there, where the fetus basically gets bathed with spirochetes. When the fetus is infected, it's really going to go to most tissues. It's really interesting how spirochetes cause their issue, because you remember that picture, kind of the word looks like a worm, looks like a snake. What it does is spirochetes are actually able to kind of slither in and go in between cells And so they're able to very easily penetrate different organs and tissues because they can really move in between cells. So, but especially the bones, the brain, the heart, the kidney, the liver, the spleen, and the skin are the ones that are going to be most affected. And then depending on which organs are affected and how badly they're affected is what will be the spectrum of clinical illness. And it can be anything from asymptomatic cases to death. Remember, damage to the cells is caused by both direct invasion and movement between the cells, which I was just describing, but also this invasion of these spirochetes causes an incredible inflammatory response. And so you have the organ invading, and then on top of it, you have the inflammatory response, and the inflammatory response can cause its own damage as well. So you have the flame of inflammation. And then the other thing that it does, which is why I have this wolf in sheep's clothing here, is that the Treponema pallidum is actually able to kind of disguise itself from the immune system pretty well. So the immune system at first doesn't even recognize it as an invader. All right, so when does transmission occur? Basically anytime and any stage. So early in pregnancy, the fetus lacks an ability to even mount an immune response. The immune response doesn't really kick in until around 16 weeks. Second box there is untreated early syphilis results in worse outcomes because the fetus is just developing, and now you have these fetal tissues with this massive invasion. Fewer than 20% of infants will be unscathed without an intervention in the early cases. And then the transmission rates, though, primary will differ by the different stage of syphilis. So primary will have a 29% transmission rate, secondary at 59%, early latent at 50%, and then the late latent really has the lowest transmission rate. Probably at that time, there's the immune system from the mother is able to kick in and actually prevent it, the level of the spirochetemia. So case definitions are a little bit hard, and it was revised in 1988. So if you look at things from before 1988, back when we had significant syphilis then too, you may see different rates based on the definition. So a syphilitic stillbirth is the death of any fetus weighing more than 500 grams or a gestational age greater than 20 weeks in which the mother was inadequately treated for syphilis. So if there's a stillbirth and those two things exist, it's assumed that the stillbirth was from syphilis. A confirmed case really is that you have to have evidence of Treponema pallidum in a lesion in the placenta, the umbilical cord, amniotic fluid, or an autopsy, and nobody looks at those. It's very hard to find Treponema pallidum, and so we were really underestimating in the reports how much syphilis there was. So right now we have a presumptive case, which is when you look at statistics of how much congenital syphilis we have, it's based on these things. So an infant or child with a reactive treponemal test for syphilis, and then one of the following. So the child has to have the reactive test and then evidence of syphilis on physical exam, and I'm going to talk about physical exam, evidence of syphilis on long bone radiographs, which are pretty specific, reactive cerebral fluid VDRL. Remember I said I was doing 1 to 2 spinal taps a day back when I was at Temple. Elevated cerebral spinal fluid count of protein without another cause, or a quantitative treponemal serologic titers that are 4-fold higher than the mother's. We get very good at doing almost the math on our fingers of what's the mom's RPR and what's the baby's RPR, and sort of moving forward based on that. And then finally, a reactive test for FTA-ABS IgM antibody. IgM antibody is the one that is produced only by the fetus. It does not cross the placenta. Whereas an IgG antibody, you don't know whether you're testing the mom's antibody or whether you're testing the baby's antibody. But the IgM antibody is produced only by the fetus. And that's kind of a hard test to get. So really, when we're in clinical work, really what we're doing is we're looking at the other things. We're looking at the long bones. More really what we're looking at is the cerebral spinal fluid, VDRL, cell counts, proteins, that type of thing when we're trying to come up with an answer. So early versus late congenital syphilis. The majority of infants born with congenital syphilis, again, are going to be asymptomatic. So it's pretty easy to miss the cases unless we have this high index of suspicion and that we do the appropriate screening and testing. I'm probably going to say appropriate screening and testing at least 4 or 5 times in my time with you. So early congenital syphilis occurs within the first 2 years of life. And even then, most of them are occurring within the first 3 months of life. And even with that, the majority of them are going to be symptomatic within the first 5 weeks of life. So that those are the ones that, you know, have, usually there's a pretty high suspicion of those. Although I'll back up for a second, I have been in an emergency room where babies have come in around 3 or 4 months of life with a classic congenital syphilis rash, and you go to track down their testing, and there was either no testing done or nobody knew what the testing was, and they did not get referred for care. So late congenital syphilis is something that occurs after the second birthday. So it's a different pathogenesis and will not be symptomatic early. And instead, it's stuff that will become after the second birthday, usually much later, and something that you have to have a really high index of suspicion for this. So the physical examination clues to early and late congenital syphilis, so that when you're in the nursery or you're dealing with a baby who's newborn, even within the first couple months, that, more than 80% of them are going to have an enlarged liver and are going to have the skeletal abnormalities. So a baby with an enlarged liver is a real tip-off that if you have a baby with an enlarged liver that is in the sort of the right context of, really want to sort of go back and double check, that an RPR was done. The majority of babies will be smaller, birth weight less than 2,500 grams. And then these other ones down here are more sort of the 20 to 50%. Often the thing that has brought the baby to attention is the skin lesions. They may have slightly elevated bilirubin levels that don't come down as quickly as you would expect for babies that have normal hyperbilirubinemia, may have pneumonia, splenomegaly, anemia. Snuffles is something with just a really, really awful runny nose. Painful limbs, pancreatitis, CSF fluid abnormalities. Again, this sort of syphilis in adults being this sort of great imitator can present as so many different things other than something that you would be thinking about it, that you're only going to find it if you're thinking about it. And then the more unusual things of nephritis, failure to thrive, testicular masses, chorioretinitis, very, very unusual. Chorioretinitis comes with the other congenital infections of things like CMV and toxoplasmosis and things like that. Much more rare in congenital syphilis. And then hypoglobulinemia. So things that are, if the baby is going to be symptomatic, these are all things that are, not so subtle things. Then we get to late congenital syphilis, which has an entirely different presentation, because this is a baby that has been infected for years and years with this low-level infection with congenital syphilis. So majority of them will have this frontal bossing, which is the frontal bone, the forehead sticks out and is really prominent. And then the maxilla is the upper jawbone. That one is shorter, and so you'll have a big the forehead sticking out more, and then the jawbone, the upper jawbone, sort of receding. They'll have high palatal arches. There's something called the Hutchinson triad, which we'll talk a little bit more about later, which is inflammation of the cornea. The teeth will be not right, and deafness. And you can also have this protuberance of the lower jawbone. So, it becomes really tricky with that. Is it the top one shorter? Is it the bottom one sticks out more? And something called saddle nose, where the main bone in the nose is sort of eaten away and the nose sort of recedes a bit. Interstitial keratitis, again, these are the more unusual things. Fissures in the skin at the angle of the mouth, mulberry molars, saber shins. These are all like these things that appear on the list of things that you can have from syphilis that aren't quite as common, but things you need to kind of keep your eye out for. So the early congenital syphilis presents more of sort of like what you would expect an infectious disease to be, inflammation of different parts of the body, pneumonias, enlarged liver and spleen. Late congenital syphilis is something that is the sequelae of many, many years of having spirochetes present. The bones don't grow well, and this sort of chronic inflammation. So let's do some cases. So first we have baby Jerome. So he was a 6-week-old baby. He was brought to your urgent care center for a diffuse rash by his foster mother. 2 weeks ago, she took the baby to the primary's office because of the worst runny nose she'd ever seen. And they did a viral antigen panel that was done, and it was negative. She also states the baby's more irritable than she's used to, even with babies with in utero drug exposure, something she assumes the baby has, but knows very little otherwise of the prenatal history. He was just kind of dropped off with her as a foster mother. She's a really experienced foster mom, and is saying there's something just not quite right about this baby. On physical exam, the baby's 25th percentile for all his growth parameters. He has a thick yellow nasal discharge, tinged with blood. His heart and lung exams are normal, but his liver is palpable just below the right costal margin, and his spleen tip is also palpable. He has a soft, non-tender, slightly enlarged nodes in his axilla and groin. He has a diffuse papular rash that in places looks vesicular, and he's starting to peel on his palms and soles. All right, so this is the snuffles that I was talking about, the worst, really. I mean, most babies that have a runny nose have kind of a clear runny nose, at least when it starts. And the runny nose for snuffles is just dark, and it can even be tinged with blood. This is the rash here. It's sort of a typical congenital syphilis rash. This is one that if you're in a hospital really experienced with this, which I was at one point, that the nurses would notice this right across the room and say, there's a baby over there with congenital syphilis. And the peeling palms, another. All right. You notice the foster mom has a lesion on her lip, and you ask her about it. She tells you it just appeared and she thinks it's a cold sore. So you decide to walk the baby over to the emergency room for a more thorough evaluation because this baby's sick, and where you also work. So you're able to just walk the baby over. And so these are some blood tests that we can get. So we're going to have sort of, I can't see your hands, but we're going to have people, for yourself, raise your hand of how many people think we need to get a complete blood count now, or later, or we don't even think it's needed. How many people think we should get an RPR on the baby? Again, now, later, or not needed. Mark this on sort of your own bingo card. Whether we need a treponemal test and whether we want to wait for the RPR, whether we just want to go ahead and get the treponemal test, or at least do it in a place that we can have a rapid turnaround of the treponemal test. Lots of places you get an RPR and you can get the treponemal test back almost instantly at the same time. Some places an RPR can be done quickly, but the treponemal test is set out and you're not going to get it back for a couple of days. Liver function tests, now, later, not needed. Whether we need to do a spinal tap now for a VDRL, whether we think we need HIV testing in this baby, bone radiographs, and whether we need a dark field exam or not. And the dark field exam actually looks for the spirochetes. So this is what we're going to do. Basically, all of those tests up through cerebral spinal fluid exam, we're going to do now. The mom says the foster mom says the baby's irritable. The baby has a large liver. The test is pathognomonic, well, not pathognomonic, as close to pathognomonic as you can get for syphilis. And of course, you're going to want the complete blood count. HIV testing, I used to be an HIV doctor, so I HIV test someone just because they're in front of me. You could make an argument it'd be okay to wait until later because it's not going to change what you're going to do now, but this baby definitely needs an HIV test. And the question of bone radiographs. So bone radiographs are one way that in a baby who has low symptomatic levels of congenital syphilis is kind of one of those mostly asymptomatic, maybe has just a couple things, the bone radiographs will help you make a diagnosis of one of those babies. This baby, we're pretty sure this baby has congenital syphilis. We could get a bone radiograph later. It's not going to change our management at this point, so we can get it or not get it preferably what I would do is not do it, because you're going to expose the baby to extra radiation that you don't need to. And the dark field exam that used to be required to be able to make that complete diagnosis, we're probably not going to do the dark field exam, but it still would be cool to do it, because I think dark field exams are pretty neat to look at. So the results are, he has a mild anemia with a normal white cell and platelet count. His RPR is positive to 1 to 124. We don't have the moms to compare it to. We might be able to get the moms, but that's pretty high RPR. The treponemal test is positive, 2 times normal liver enzymes with a mild hyperbilirubinemia. His CSF cell count is mildly elevated, which would be typical. They're not like these really, really high levels, and the CSF VDRL is positive. So this baby has congenital syphilis and is going to need to be treated for congenital syphilis. So Jerome has symptomatic congenital syphilis with neurosyphilis. And what's the deal with his foster mom's lip? Well, one of the things that you want to think about in these babies is that rash is just oozing spirochetes. So, I mean, she's a good foster mom, so she was probably been kissing him and rubbing his face against hers and things like that. And so mom, the foster mom, actually has syphilis that she has acquired from the baby. Which again, back in the bad old days, the emergency room, the very first thing you would do with one of these babies before you approached them was to put gloves on. So testing and treatment pearls for early congenital syphilis is that the diagnostic positive RPR in the infant titer is 4-fold higher than the mom's. So if the mom is 1 to 8, the infant's going to be 1 to 128. So 1 to 8 to 16 to 32 to 64, and then 128. With an abnormal physical exam, the titer is less important, because you can make the diagnosis just based on, if say you had characteristic bone findings, or with a high probability of diagnosis, other testing is less important. Like I said, you don't need the bone x-rays. Treatment for symptomatic is diagnosis in the first month of life. We're going to give aqueous crystalline penicillin G, 50,000 units per kilogram per dose intravenously every 12 hours for the first 7 days, and then every 8 hours for a total of 10 to 14 days. Or you can give aqueous procaine penicillin G, 50,000 units per kilogram per day intramuscularly for 10 to 14 days. I'll tell you, I mean, this is a rock on a hard place, because these babies usually don't have great venous access. It's hard to keep an IV in them, and you need to usually keep the baby in the hospital for the 10 to 14 days. Whereas the intramuscular one, you can send the baby home and have a visiting nurse or somebody, usually a visiting nurse, come and administer it intramuscularly, but it hurts. The babies get really sore for 10 to 14 days of a fairly high volume of penicillin. Diagnosis after 1 month of life is aqueous penicillin G, 50,000 units per kilogram per dose, every 6 hours intravenously for 10 to 14 days. So slightly different. You don't have the stepped up 7-day, then 14-day. And also children who with HIV exposure, you also treat them this way. Treatment for asymptomatic is 4-fold higher titer and mothers insufficiently treated. You do the same as symptomatic, or you have this other option of giving the benzathine penicillin 50,000 units per kilogram per body weight dose IM in just a single dose. You don't have to give that 10 to 14 days. And so the difference in here is asymptomatic, you have the option for just the single dose of IM penicillin. But if the child has an HIV exposure, you can't use that. You need to make sure that you treat them the same as a baby that is symptomatic with syphilis. That's a mouthful. So the other findings, this is a picture of why we do the bone findings. So this is a saber shin, or an early saber shin. You see here with the arrows, this is that there's a little bit of the bone eaten away here from the inflammation, and this is that you see, we call reaction of the bone, that there's a little bit of inflammation in the bone here. So this would be the osteitis, and this would be the sort of the early beginnings of what we call saber shins. Hydrops fetalis is a very severe form and often can result in a stillborn baby. In it, the baby is severely anemic or has severe, all the body tissues have congenital syphilis, have treponines in them. You get fluid surrounding the lungs, you have a swollen fluid filled abdomen. These babies are really, really tough to take care of when they're born. It's very difficult to ventilate them because there's so much fluid. These babies tend to not do very well. All right, case 2. So case 2 is Tabitha. Tabitha is an 8-year-old who's brought to the primary care doctor because her teachers want her to have an evaluation for ADD-HD. After being a solid B student, she's recently become disruptive. She's not completing her assignments. She's acting as a class clown, telling everybody she's a vampire. Other than a few episodes of otitis media when in daycare as a toddler, you've seen her only for routine child exams. She's growing well, up to date on everything. This was not a child you had on any lists of ones that you were worried about. As you thumb through her chart, you notice in her birth record that her mother was treated with pills for syphilis during pregnancy, but no other complications, and the lab testing done at the time is not on her chart. Something in her dental record, though, catches your eye. And somebody had written that the dentist had written that she had unusual teeth. All right, so you perform vision and hearing screening. That's easy to do in your office. And she fails both. And you concur that she does indeed have unusual teeth. What do you do next? So here's Tabitha. Her RPR is 1 to 64, which it should be 0 now. Now the point is we're not now looking at comparison to maternal RPR, which is any child beyond the immediate time after birth who still has an RPR that's positive. It's his or her RPR, and the FTA-ABS is positive. At this point, you're also not thinking about whether this is maternal transfer, because maternal transfer of antibody is gone usually by 18 months. So this is her eye exam. She has keratitis right here, inflammation of her cornea. This is her audiogram. She has sensorineural hearing loss, and these are her teeth. This is called Hutchinson's teeth. She may have mulberry molars too. They're in the back, but these are her teeth, and you can see why in her acting out, she was saying that she was a vampire. So hospital birth records show that her mother was treated with erythromycin during pregnancy, and that no RPR was performed on Tabitha. So this is what happens when people, don't follow the appropriate appropriate treatment regimens, which the mother in pregnancy must be treated with penicillin, and that RPR, regardless, needs to be done on the baby if the mother had a syphilis during pregnancy. So here's a bonus case. Okay, here's a bonus case. So Robert is a 10-year-old boy who was brought to your office 1 month ago with lesions on his tonsils and cervical adenopathy. His strep test was positive, and you treated him with amoxicillin. Yesterday, he returned with fever and diffuse lymphadenopathy. His rapid test is still positive, and you started him on amoxicillin. Last night, he developed a rash that has continued to spread and now include his palms and soles. So you're thinking, probably has mononucleosis. Very, very common for a child who has mononucleosis, that if you treat them for a strep infection, that they actually pop up with a rash. So you order a mono test, but somehow instead an RPR is done. Someone checks the wrong box someplace, and his titer is 1 to 256, and he has a positive FTA-ABS. This is what his throat looks like. Nothing that would make you think other than that it's strep throat or that he has mono. These are his palms, though. This is his rash. This is this rash that is not at all a typical rash that you would get from mononucleosis. This is a rash that's a macular papular rash on his palms, also has them on his soles, and this is the rash that's on his back. That this is another one of those rashes that if you've seen it, you know what it is. And if you've seen it and have the right diagnosis, probably something that most pediatricians won't have seen, and so won't necessarily recognize this as a secondary syphilis rash. So who wants to vote that this is a false positive RPR and FTA-ABS? All right. Who wants to vote that this is late congenital syphilis? You don't have symptoms of secondary syphilis with late congenital syphilis, because as we talked about, late syphilis, congenital syphilis comes from having years and years of syphilis in your system, just eroding away the inflammation. So who wants to vote that this is sexual abuse and he now has secondary syphilis, and that all of the symptoms he has right now are actually primary than secondary syphilis? So he needs to be treated regardless of his age, this as a patient with newly acquired syphilis, not congenital syphilis. So the treatment for him would be benzathine penicillin G, 50,000 units per kilogram, up to the adult dose of 2.4 million units IM in a single dose. And then he's going to need really close follow-up. You need to evaluate for other STIs, including in HIV, especially in HIV. I have seen babies in my clinic when I was in Pennsylvania that had syphilis and also had HIV. Not babies, I'm sorry, teens. Follow the RPR for return in titer to negative. You're really going to want to make sure that his titer goes back down to 0. And if it doesn't, retreat him. And certainly report to Child Protective Services. All right. So congenital syphilis prevention, really, we can't focus on the babies to be in the prevention that we need. What we need to do is really a holistic approach to prevention of adult syphilis. Because if you prevent the adult syphilis, you prevent congenital syphilis. We need to focus on women at all their points of care, including but not limited to service for substance abuse, prenatal care, family planning, urgent and emergent care. Women with the characteristics that we talked about, at least from the Chicago experience, are not folks that are going regularly to a primary care doctor and can get screening that way. So you're going to, focus on doing syphilis screening in places that aren't the typical places that you would think of as primary care, but people when they show up to an emergency room, or people who are getting family planning services, and including their male partners. It's not sufficient to look at the women. You need to make sure that the male partners, because if you decrease it in the male partners, you're going to decrease it in the women. Needs to be awareness in providers so that appropriate testing is performed. I talked about how I had kind of lost track of how the syphilis rates had gone up. I think that the majority of providers in this region will not understand that will not be knowledgeable that the rates have gone up in Minnesota, and be thinking about being really on the dot with doing screening. And then, of course, you can't take care of any of this without taking care of the sociocultural determinants of health that interfere with the wellness, that this is a societal disease. This is not just a medical illness. And then in conclusion, syphilis has been with us for millennia. This is a picture of Al Capone, who was one of the first patients to be treated with this new wonder drug called penicillin, and it was for syphilis that he had. So syphilis has been with us for millennia, but we do have the power and tools to do something about it now. We have penicillin, we have the ability to screen, we have algorithms to be able to screen. We just need to mobilize what we're doing to be able to do it. And with that, I will finish, and I think there's time for questions.
Yes, thank you for that excellent presentation, Dr. Foster. We don't have a ton of questions, so folks, please feel free to throw some in the Q&A box. We did get one while you were presenting. It's in reference to the slide you presented on the Chicago study of cases. And the question is, does Dr. Foster know what percentage from the Chicago data of women with psychiatric illnesses were using non-injecting drugs consisting of methamphetamine or oral opiates? And the reason why is because in Minnesota, we do see the pregnant people who are affected by syphilis reporting drug use under methamphetamines and other things like that.
Yeah, the table didn't have that. The table just said which percentage of each category. The table did not include which people had both, but I would guess that it's a pretty high number that is both.
Mm-hmm. Yeah, awesome. We do not have any other questions, but folks, throughout the time, please feel free to reference Dr. Foster's presentation. If you do have any other questions, we can always circle back, or I can email after the fact. But thank you so much for your presentation. That was very informative, and I appreciate you going first. So with that, it does look like Dr. Contag was able to join us while Dr. Foster was presenting. So Dr. Contag, if you're ready, we can get started with your presentation.
I am ready. I just can't get my video going, but yes, I'm ready.
Okay, cool. We'll have you introduce yourself and then share your screen.
Okay, let me see. It says the host has stopped my video.
Oh, okay. Brenton, can you get Dr.
Yep, I just fixed it. Yep, you
Okay,
should be able to share
cool.
your screen and video.
Thank you.
Oh, there you are.
Thank you. Thank you, Dr. Foster, for stepping up. I was stuck in a fetal transfusion, but everything's taken care of. So please excuse me for being late to my presentation. So I'm happy to share the information. I was here actually for Dr. Foster's presentation, and I think she did a great introduction of some of the things that I'm going to be talking about. I would like to jump into my presentation, and I'll put up my screen now. Share screen, get my presentation up. And let's see. Here we go. You should be able to start to see it here, and I'm going to go into presentation mode. And you're seeing the wrong screen, so I'm going to switch the. Okay. So hopefully you're seeing what you're supposed to see, which is syphilis and pregnancy updates. And I'm just going through some of the recommendations that are put out there based on data.
Dr. Contag, we
Yes.
actually can't see your screen yet.
Let me see. Let's see. Screen, share screen. Not yet.
Oh, let's see.
Let's see.
No, and I don't know if I'm just not seeing it. Brenton, do you see anything?
No, I'm not.
Okay.
Should I switch over? I logged in, but let me see. Share. How's that? Not
That's
yet.
perfect. Yep, you're
Okay.
good to go.
Thank you. So let me go back to my screen share now. Okay. So going based on the recommendations from the Minnesota Department of Health, CDC, as well as information provided for them, I wanted to talk about updates. I have no disclosures to report. The goals of this presentation are to identify syphilis in pregnancy, what laboratory tests we do for the diagnosis, and treatment guidelines for syphilis in pregnancy. Just a nice picture of a spirochete. Now, this is a problem because this gives the impression that it's a corkscrew shape, but actually it seems to be one plane and just has a curved shape where it goes kind of like zigzags back and forth rather than forming that corkscrew. But the reason why this is important for us in pregnancy, even though syphilis is not the most common or prevalent sexually transmitted disease, it's the one that can cause the most harm to the pregnancy per se. So looking back, as you've probably seen some of this data, we can see how the rate of syphilis in the female population of reproductive age, 15 to 44 years of age, has gone up, together with the frequency of congenital syphilis cases, as attested by the bars on the same chart. Going through this imaging, we can see how Minnesota has an intermediate position. It's not the lowest, it's not the highest rate, but has an intermediate position as far as the frequency within our population. This is in comparison to other sexually transmitted diseases. Here I just show chlamydia, for example. Even though the curve is going up slightly, it doesn't look like it's very steep. This is in the thousands. There has been an increase, but over the last couple of years, there's been a drop. And I don't know if this is due to COVID or there are other factors that are related to this, but there has been a drop in the rate of chlamydia in the population. Gonorrhea, on the other hand, which has a much lower frequency and therefore the curves are much more marked, has continued to show an increase and over the past time. But that's parallel. It's similar to what's been happening with syphilis. And even though I'm going to go back 2 slides, chlamydia, the frequency is in the thousands per 100,000, and the frequency for gonorrhea is in the hundreds per 100,000, and the frequency of syphilis is in the tens per 100,000. The fact is that it has gone up substantially over the past 10 years. And so I think that's really important. And it just kind of raises the importance of how we need to be aware and how we can help extend our awareness of this condition, how we can address it, especially in the pregnant population, which is the group of women that I work with. Data from the Minnesota Department of Health showed that the number of cases was, like I said, in the tens. There were 70 cases reported between 16 and 17 with early stage syphilis making up about 25%. Those detected at 28 weeks, these are all pregnant cases, right? Another 28%. And then detected on admission, that were negative at 28 weeks, there were none. So the point is that early detection, as well as the detection at 28 weeks, are really important. And I'll go into some reasons why they're the most important find of detection. Even though we do try to detect later on, the opportunity to treat and prevent congenital syphilis is best when we detect it early in the first trimester or up until the end of the second trimester, which we'll call that cutoff 28 weeks, which is technically marks the difference between the second and the third trimester. So when we try to figure out why these things are happening, this nice chart from the CDC just shows how, aside from the fact that the prevalence has gone up, as can be seen by just the gradual increase in the stepwise increase in the incidence. The reasons that have kind of been identified are no adequate maternal treatment despite receipt of timely diagnosis. So these are patients who were diagnosed in the first or second trimester, but were not treated in a timely fashion. And I suspect that one of the reasons that can happen, there may be more than one, is that either patients don't return for care or the test is run, but follow-up wasn't appropriate. The second most common reason is that there's no timely prenatal care, no timely syphilis testing. So if the test is not in our minds, it's just kind of out of sight and we miss the opportunity. By the same token, if a patient hasn't come in for prenatal care in a timely fashion, that can also interfere with the testing and the opportunity to prevent this condition. And as we'll see, that's probably one of the main reasons why we have this ongoing problem in pregnancy. It's that group of that population, that the disadvantaged women who have difficulty accessing care or just don't have access to care, and or lack of awareness of the providers on how important it is to make that early diagnosis. The third most important reason is late identification of seroconversion during pregnancy. So when patients are identified in the third trimester, we still need to identify them because we need to treat the newborn infant, as we've just seen. But when we treat in the third trimester, we're not always able to prevent the transmission. There is some prevention, but not 100% prevention or a high rate of prevention as there could be with early first and second trimester treatment. There's no timely syphilis testing despite receiving timely prenatal care. That's less common. And clinical evidence of congenital syphilis despite maternal treatment completion. So these are cases where either treatment failed or patients got reinfected despite being treated in a timely fashion. So back in 2016, the recommendation was that patients should be treated at initial prenatal labs in the early third trimester, ideally by 28 weeks, and then upon inpatient admission. The problem was that it was very difficult to get those patients, or they were missing a lot of patients who were not treated on admission. And so in 2019, a second, despite the fact that there was a 3-point testing period, which is first, second, and admission, first, second trimester and admission, the incidence of the condition continued to rise despite adequate treatment recommendations. The rise was between 2016 and 2019 was about 400%. So I think that based on that, the subsequent recommendation was a little more focused. And in 2019, the emphasis was on screening, at least at the first prenatal visit and early in the third trimester, 2030. And then it was also important to specify that all cases of stillbirth after 20 weeks should include an RP, either a triple antibody test, a direct test, or an indirect or non-triple antibody test to screen amongst all stillbirths after 20 weeks. The third part of it, or the other part of that screening in 2019 was not to discharge the patient, So it wasn't on admission that you necessarily need to be tested, but not to discharge a patient until there was some documentation of maternal syphilis testing in the third trimester. And if not available from the third trimester at the time of delivery. So the point was not the emphasis at the time of admission, but before the patient is discharged to home, that had to be documented. And then the other part of that recommendation, so it became a little more elaborate, is that we should screen all high-risk women at the time of delivery, regardless of a negative third trimester screen. So this basically said we don't have to screen everybody at the time of delivery, but we did add these 2 extra recommendations that state, don't discharge and make sure you screen all high-risk women. I'm just going to try to get my camera into the right position here. So what are those high-risk conditions? Well, here we've identified those risk factors who are considered to be high risk and warrant additional screening on admission to labor and delivery, regardless of what the third trimester screening was. So if there was no or inconsistent prenatal care, history of sexually transmitted disease during the past year, illicit drug use, incarceration in the past year, currently experiencing homelessness or unstable housing, multiple sexual partners, a sexual partner who's had any of the above conditions, or if the clinician has any suspicion, deciding to screen for any other reason at the time of delivery. So what did this lead to? So the pearls relative to screening and pregnancy is that syphilis has the lowest number of reported cases of the 3 STDs. We've seen that. There's a high index of suspicion is required when trying to diagnose syphilis in any individual, not let alone pregnant woman. And there should be a low threshold for testing for syphilis. It's important to realize that progression of syphilis can occur, especially the early stage syphilis tends to progress a little bit faster. It's a little more infectious during the first primary, secondary, or early latent stage, which depending on who you ask is either the first or the second year from infection, which is when there's more active replication of spirochetes, which is when that individual who has the condition is more likely to transmit it, whether it's to another individual in horizontal transmission or whether there's mother to child transmission. Those early stages are the ones where you have the highest risk of transmission. There can be transmission in latent stages, especially vertical transmission, which is what I'm going to focus on, but the transmission rates are much lower the longer the individual has had the condition. And that doesn't mean we don't have to screen, but there is a lower rate of transmission in the late phases of syphilis. Syphilis can cause considerable morbidity, and it does facilitate HIV transmission. And that's important to remember, the treatment is pretty straightforward. So this is just a slide. I'm not going to burden you with this. It's just the fact that the primary infection, the primary chancre, usually presents within 2 to 3 weeks of local infection, wherever the transmission occurred. So from the moment that contact occurred, within 2 to 3 weeks, the first signs of primary infection will show up. Whereas the secondary infection can take up to 6 to 12 weeks before it shows up, and it'll continue. It can recur in about 25% of patients. The rash that's associated with secondary infection continue to recur over several months after the initial manifestation of the condition. And then early latent is considered to be asymptomatic. The patient has no lesions, no rashes, and that can last up to 1 year. In some cases, the World Health Organization specifically says up to 2 years from the time of the initial infection, whereas late latent is after 2 years, 2 years and beyond. Tertiary is the late asymptomatic that can appear decades after the initial effect. And that has to do with the fact that once the early phases, the bacteremic phases and the early extension of the treponema within the individual has been infected has kind of settled down, the immune system of that individual kicks in and it suppresses replication. However, at some point in that individual's life, wherever that treponema has decided to nest and set up shop, it's going to start to cause damage, whether it's in the cardiovascular system, within syphilis, within some of the viscera, within the central nervous system, within the bones. Somewhere it's going to set up shop, and it's going to start to cause manifestations at some point in that individual's life, once that individual's immune system starts to become less effective. And then the other thing I wanted to make a point of in our just as a brief point, is that neurosyphilis, which is usually considered to happen more often in the late symptomatic stages, can occur at any stage, and it can occur even early in secondary syphilis, but it's very rare in these early stages of disease. So the most transmissible stage for syphilis, and this is now relevant, very relevant to pregnancy, is that it's in the primary stage. So the primary stage, secondary stage, and early latent stage, which is considered early syphilis, as opposed to late latent tertiary syphilis, which is considered late syphilis, is when most of the transmissions occur. So with that in mind, in utero transmission can occur at any latent stage, of syphilis, more likely to occur in the early or early latent stages of syphilis. So that leads to the point, when do we test? Why should we test? Why don't we just wait until later on in the pregnancy and just test everybody once and then we'll be done with it? Because the infection, as was pointed out, as we've just seen, can infect the pregnancy at any time. It's been shown in cases of women who had primary syphilis at around the time of conception that as early as 9 to 10 weeks, you can find evidence of treponema within the products of conception. And so we know that the actual damage that syphilis can produce in the fetus is not really so much a result of the presence of the treponema in the fetus. It's more as a result of the immune response to that infection in the fetus. So the fetus within the first 18 to 20 weeks is just starting to develop its immune system. So it's very unlikely that, unless we test with serology of some sort, that we would detect or see anything happening to that fetus before 18 or 20 weeks. Once we get to that 18 to 20 weeks, once the fetal immune system starts to kick in, then there's a response to the infection, which gradually develops, can lead to growth restrictions, stillbirth, hydros, placentomegaly, all of the conditions that we associated with fetal infections. And then after the birth, all of the complications that we associate with a neonatal infection. So detecting early is important because we can avoid that early transmission or treat the fetus that's been affected early. In fact, if we treat the fetus early enough before that 18, 20 weeks mark, when the immune system starts to actually kick in and cause the response that leads to the damage in the fetus, we could actually prevent most of that damage to the fetus. If we detect the syphilis later on in pregnancy, before damage has occurred, treatment will also prevent that damage. The problem is that it hasn't been detected, and it was an early acquisition, either in the first or the second trimester, wasn't detected. And by the time the fetus is born, it already has showing the changes. Then we kind of missed the boat on trying to prevent this infection. So the crucial time to treat patients is really at the time of the first prenatal visit in the first trimester, at the time of the second, late second trimester, when we do our 28-week labs, which is standard of prenatal care. And then for that high-risk population, the third trimester at the time of delivery, with the knowledge that to be able to treat this patient and to actually prevent perinatal transmission or mother-to-child transmission of this condition, that it's only really first or second trimester up to 28 weeks that will treatment, which will give it time to kick in and prevent that transmission. Once we start treating the fetuses in the third trimester, the number of cases that will respond to that treatment gradually decreases because there isn't enough time. Syphilis reproduces, the treponema pallidum reproduces it's very indolent in its reproductive rate. And so it takes that extended exposure to the penicillin to actually remove it. And that last trimester of pregnancy won't always allow enough time for it to happen. Obviously, the closer we are to the time of delivery, the less likely we are to eradicate it, and the more likely that infant is going to require treatment after delivery. So as far as what's legally required in the state of Minnesota, if we go down to like halfway, I don't read that little tiny script there. There is no legal requirement. There was not at that time in 2018. I'm sure there's some of you who can bring me up to speed on this, but for most states, there is no legal requirement for treatment at the time of delivery. There's a first trimester, and there's this, I wrote third trimester, but this is actually late second trimester, early third trimester that's required, but there's no standard requirement for treatment at the time of delivery. But our state, as I showed you early, does have that requirement. So how are we going to treat these patients, or how are we going to diagnose it? Well, I'm not going to go into this because I think that's already been addressed. We have two algorithms. Well, first, let me say there's two types of tests, which have already been described by Dr. Foster. One is the non-treponemal test. These are serologies, by the way. All of these tests, both non-treponemal and treponemal tests, are serological tests. There's no other. This is how we base all of our diagnosis. And we barely, it's very rare that we do dark field examinations or PCRs. And the reason we don't do PCR, which is a more contemporary technique is that it hasn't been standardized for everybody to use the same technique. And so we rely on serology for our testing based on non-treponemal and treponemal tests. The traditional testing pathway, which I was raised with and trained with, was the traditional. So you start with a non-treponemal test and then you transition to a treponemal test. Well, because we've developed high throughput standardized tests, which are either chemiluminescence testing, immunoassays, CIAs or EIAs, enzyme immunoassays. These high throughput testing have shown to be more sensitive, and I'll explain why in a minute, for testing, which has led to an adoption of reverse sequence screening. Now, this isn't a worldwide plan, but in countries such as ours, where we do have access to the laboratories that can run these high throughput standardized tests that are run on a machine, that don't depend on somebody eyeballing a test tube and see how much, flocculation has occurred or how much precipitation has occurred, but actually just run it through the machine, have proven to be a little more sensitive and specific for the diagnosis. So most places around the country have switched over to reverse sequence screening for their standard testing. So they start with the treponemal test, and then they do the non-treponemal test to quantify the level of non-treponemal antibody. So this is just comparing the two. The traditional test has the qualitative non-treponemal test, whether it's one of these two, and then if positive, they go to a confirmatory treponemal test. And if that's positive, that patient will be treated. If this is somebody who's never been exposed to syphilis, the problem this is non-treponemal to treponemal, and then they're treated. And so the problem with the non-treponemal test is that I was saying that the primary lesions, if we're looking at early syphilis, the primary lesions appear roughly 2 to 3 weeks after the exposure. So the primary lesions appear then, but the antibodies, these non-treponemal antibodies, don't appear until about 2 to 3 weeks after the lesion. So it's a problem as far as the timing of the decision. So these will become positive, but they tend to be somewhat delayed, and that leads to a lower sensitivity compared to the treponemal testing, which is the reverse algorithm which we're using based on the enzyme immunoassay or the chemiluminescence assay, immunoassay, which will start to convert before the non-treponemal test does. Usually the treponemal testing will start to convert within a week or two of the lesion appearing, which gives it about a week advantage in terms of how soon it can detect somebody who's been recently exposed to syphilis. And that's helpful, and that's probably what has the best impact on the sensitivity. Whereas with this, we could miss a group of patients if the testing is performed too early. In any case, once we have a positive treponemal test, we would have to figure out two things. One is there a previous history of treatment? Because the thing about the non-treponemal test is over time, they wane. If a patient was treated adequately, or even if she wasn't treated, as the disease progresses or treatment was implemented, approximately 90% of patients will completely clear their antibodies, whereas in about 10 to 20, there will be persistence of these antibodies at a very low level. There's serofast patients. Whereas with the treponemal test, these antibodies will remain for lifetime. So somebody who has a positive treponemal test, as you all well know, could either have been previously infected and treated, or previously infected, never treated, or recently acquired the infection. The test doesn't tell us that. So it's important to know what the history is before figuring out what to do. And then if there is a history of treatment, then we need to treat it. Then we just need to run the RPR to find out what happened. So if a patient was treated in the past, and then you have to run the non-treponemal test. If the patient was not treated, has never been treated in the past, then that patient should probably be treated, even if you don't have the RPR yet, because there's been no history of exposure. But in the patient that was treated, or even if you didn't know if they don't know if they were treated or not, or they don't know what their history is, then you still want to run the non-treponemal test to move again to treatment. So the main reason these have switched is, one, this is a high throughput test. It's standardized test. Labs can run it very quickly, and it gives you a slight advantage in timing from the moment of the infection to the moment the test is positive compared to the non-treponema test. If we basically look at the curve, this came from this Nature Reviews. I highly recommend this review. And looking at it just gives you more than you ever wanted to know about the treponema. But the main issues are, like I was pointing out, early syphilis versus late syphilis. And it shows how the treponemal antibodies, the specific treponemal antibodies, start to appear in the individual system 1 or 2 weeks before the non-treponemal will appear. And then the treponemal antibodies remain present for life, whereas the non-treponemal antibodies, even without treatment over time, will gradually decrease in their concentration, or if they've treated, they will either drop down completely within about 6 months of treatment, or they will remain at a somewhat elevated levels, and these are what we call the serofast treatment. So in terms of the non-treponemal antibodies, it just kind of shows here, points out that how the sensitivity varies according to the stage, whereas we're in the early stages. In primary stage, if you test too early, you'll see the detection rate is slightly lower, whereas you test in secondary syphilis, your detection rate is virtually 100% at secondary stage. If you go into early latent, it can already start to drop, and then the further on you go in time, the sensitivity of the test may drop because of the dropping levels of the antibodies. With neurosyphilis, with ocular or auditory syphilis or otic syphilis, the detection rates can be much lower if you're doing serology, because the syphilis may be located within those structures and not necessarily show up in the serology. So test performance in summary, sensitivity with RPR is about 50 to 97%, depending on the timing of the infection relative to the test relative to the presence or how long the infection has been around. And then with these chemiluminescence or enzyme immunoassays, the sensitivity is slightly higher, and they're faster to process, and they're much more objective. So what does this lead us to? It leads us to several different situations. So I've established that the reverse sequence is probably is more sensitive and provides us a little more secure in the diagnosis. There are some limitations. It's important to know when we're running through this algorithm to know what the risk status of the individual is and whether they had prior treatment or not. So in this case, if the first case in this scenario, I'm going to just jump for diagnostic criteria in pregnancy. If you had a positive treponemal antibody test followed by a negative non-treponemal antibody test, the confirmatory test is needed to find out if this was a false negative RPR. So a confirmatory test is either going to be treponemal pallidum particle agglutination. This is the preferred test. There are other tests can be used, like the treponemal pallidum fluorescent antibody test. There's a hemagglutination assay, there's a microhemagglutination assay. So there's a series of direct treponemal assays that can be done on serum, but this tends to be the preferred test. It's just slightly more sensitive. So anytime we have a positive initial screen for antibodies, direct treponemal antibodies with a negative follow-up non-treponemal antibodies, a confirmatory test has to be run to find out if this is a false positive or not. Another scenario in pregnancy, this scenario is kind of what we were talking about, is exactly what we're talking about. And the factors that could influence our decision in terms of what to do, the next step would depend on whether this is a high-risk patient or considered to be a low-risk patient, or an unknown risk patient, which in pregnancy would still be considered to be a high-risk patient, and whether there was prior treatment or no prior treatment. If this patient has been established to have previously been treated or recently been treated, documented adequately, and has a negative RPR, then we can simply assume that this patient was already treated. But as I said before, these antibodies will persist throughout this individual's lifetime, whereas the RPR will gradually improve. So documenting the risk status, as well as documenting what the prior treatment status is, are fundamental when we're dealing with these patients in pregnancy. A second scenario So patients who are tend to have had more risk factors. The second scenario is a patient who has a positive chemiluminescence immunoassay, a negative non-triple test, and a negative particle agglutination test. This patient, again, it has to be determined whether this patient is high risk, low risk, or whether it's prior treatment or no prior treatment. And the reason this is important is that there could be several factors coming into play. On the one hand, this could be a false positive test. If it's at a very low level positivity, and we don't have any means to determine that, it could be reacting to some other antigen in the system that trigger the same response in this individual. But it's also possible that this is a very early detection. This is in a very early stage of the disease, and that this hasn't had time to convert yet. So as I was saying, this can convert 1 or 2 weeks before this one has time to convert and become positive. So that window would require us to repeat this test after a certain amount of time, especially if this one was also negative. So we have to be worried about the possibility of this, on the one hand, being a false negative. Another reason for a false negative is that in very early stages of disease, when we're running the non-treponemal tests, since it requires an antibody antigen response, if there is a very high antigen concentration, in other words, if the field is flooded with the breakdown products of the treponema or the cells that are being attacked by the treponema, the flocculation may not be evident. It's called a prozone effect, and it can happen in early stages when there's a very high concentration of treponema. And so when we get that kind of situation, the way around that, if you have this prozone effect with a very high concentration of the treponema breakdown products or the cell products breakdown resulting from the treponemal invasion, the way to get around is to dilute the samples. And the labs already know this. You don't have to tell the lab to do this, to just dilute the sample. And once those are diluted down to half, then they should be able to read the response, where the antibody will come and attach to the antigen, and then the antibodies will attach between each other and lead to the flocculation, which is needed to be able to read the test. So that's one reason why you get a false negative. That's the other one I mentioned, is if it's tested too early before this response has had time to develop. And then, of course, this would follow through depending on what the initial response you can have. If this may not have converted yet either. But if on follow-up there's still no response, or with dilution there's still a response, then we can assume that this is a false positive test. And of course, both of these factors have to be understood within the context of what is this individual's risk, and whether there's been prior treatment or no prior treatment. So in a low prevalence population, where if we use the reverse algorithm, it's been shown that there can be a 2 to 3-fold increase in positive tests. The number of individuals requiring treatment may increase. The cost analysis reports increased costs with this reverse algorithm compared with using non-treponemal tests, but it wasn't a significant cost. It was barely about a $50 difference, and that was in 2014 dollars. And of course, another problem is that if we use the reverse algorithm in the low prevalence population, there will be an increase in the number of follow-up consultations and increased number of cases of overtreatment. So this is in a non-pregnant population. I'm sorry, I didn't specify that. And the reason, however, when you think about the treatment that's for missing a case in the pregnant population, potentially missing a case of a fetus or an infant that's actually truly positive, the extra cost, the extra treatment are actually justified. Much more so if you have a high prevalence population. So in general, even though with the reverse algorithm may increase the number of false positive results and additional treatment and consults, the cost, ultimately the benefit of treating that population gradually increases as the prevalence of the condition in that population goes up. There is no similar test or comparison within the pregnant population. So that data I just gave you is for the non-pregnant population. So just kind of going back over the testing briefly, we have different combinations where if you have a positive, this is the traditional pathway, what we used to do. If you had a positive RPR and then you did the follow-up and they were both negative, the idea is, the recommendation is to repeat it in 4 weeks to make sure that we didn't have a false, these are not false positives or these are not false negatives. If both are positive in the traditional criteria, in this case, we would go ahead and treat this individual. If the RPR is low titer, but the EIA or the CIA are positive, this was considered to be a serofast patient, especially if there was a history of treatment. And so the same held true. If this is negative, no further testing was performed at this point. It was considered to be a false negative. In other words, this was a high-risk patient and they just simply had a prozone effect, or they hadn't had time for those antibodies to develop. There's a risk this led, and this was based on the traditional treatment. We just run the test, it would be false negative, and we would just miss that recent exposure. And so the only time we pick this up, if it was truly a positive test, would be if this patient was tested in the future, or if the clinician was requesting that test, suspected that based on the patient's history, that individual was at high risk for actually having the disease. But this is the main drawback of this test. Because those antibodies developed later, there was the risk that in early cases that we would miss the disease. And then, of course, in this case, there is a risk for if there was a negative RPR and by chance somebody ordered the treponemal test, this was the risk for missing past exposure, because if there had been no treatment and this is the profile that individual had, this would probably mean there was a remote exposure, and that further follow-up would be needed to confirm whether this is a true test or not. With the reversed algorithm, things became a little bit easier to interpret. So having had a positive treponemal test with a negative RPR and a positive particle agglutination test was basically telling us this is a patient with past exposure, especially once we've confirmed that the individual was previously treated. If there is no history of treatment and all we have are these positive tests, but the patient absolutely denies it, there's no record of treatment in the Department of Health or anywhere, then we have to consider this individual exposed and requiring treatment. Remember, the RPR over many, many years of exposure can gradually decline and may not show up positive on subsequent testing. This individual with a positive screen, but with negative RPRs and negative particle agglutination would have to be considered to be uninfected. However, it's because of the delay in the development of these non-treponemal tests, they would still recommend a repeat testing in 4 weeks. This individual will require no further testing unless we thought this was a high-risk individual, in which case repeat testing or documented history of treatment or recent exposure would be necessary. So how do we do? So we kind of looked at some of the strengths and the pitfalls of treatment and why it's important to really document treatment or the diagnosis early in the pregnancy when we can have the biggest impact on prevention of congenital syphilis. Well, on the one hand, pregnant women diagnosed with syphilis should be treated with penicillin immediately. So whether it's in the first, second, or even in the third trimester, even if we know that as the closer we are to delivery, the less likely we are to cure this individual or prevent vertical transmission, which is the second. There's two things we're trying to do in pregnancy: treat the patient or the individual who's infected, but also we're trying to prevent vertical transmission. So third trimester treatment we'll treat the individual that's infected, but it won't prevent vertical transmission, which is the second objective. So that's probably one of the pearls of looking at this in pregnancy. We're doing two things, unlike non-pregnant individuals where we're trying to treat the individual. In pregnancy, we're not only treating the individual, we're trying to prevent vertical transmission. So treatment that's more than 30 days prior to delivery is likely to prevent most cases of congenital syphilis. So the cure rate, this has been published and is looked at. The cure rate, if treatment is done within 30 days or more than 30 days prior to delivery, the lowest, you can get up to about 70 to 80% success in treatment. And then the closer you are to delivery after, from 30 days to delivery, it just rapidly decreases to zero prevention for vertical transmission. Treatment will not necessarily prevent stillbirth of congenital syphilis in a gravely infected fetus when it's evidenced by ultrasound. So if the individual, for whatever reason, had, whether by omission or by commission or whatever, or the patient to show up for their serology diagnosis and treatment, but shows up for their ultrasound, and that's not uncommon because individuals may prefer to have an ultrasound than going to a prenatal visit. If once we see evidence of congenital syphilis, which is basically high drops with severe growth restriction or placental megaly, treatment won't necessarily prevent stillbirth or obviously congenital syphilis in those infected fetuses. And then women who, so that's important. And so it's preferable I mean, it's much more effective to treat the patients before the ultrasound changes. So ultrasound diagnosis basically it's a grave prognosis for that pregnancy. And then any woman who delivers a stillborn infant after 20 weeks should be tested for syphilis at the time of delivery. So what is the treatment? Pregnant women should be treated with a recommended penicillin regimen for their stage of infection. And I'm not going to go into those links, but this is all available. So the CDC has this set of recommendations. So because we're trying to achieve two objectives, one is to treat the individual that's infected, in this case, the mother, and on the other hand, we're trying to prevent vertical transmission. The treatment that the CDC recommends is to prevent syphilis, states that to prevent congenital syphilis, which is mother to child transmission, additional therapy is needed. It's not enough to use the standard 1 or 2 doses, depending on early or late stage syphilis. You need additional therapy to be able to maintain the sustained levels of penicillin in order to eradicate the treponema from the system. So for primary CDC, for primary, secondary, or early latent, so early stage syphilis, and a lot of places just speak of early or late stage syphilis without getting into the clinical details of primary, secondary, or early latent stage, to say, is it early or is it late syphilis? For all early stage syphilis, a second dose of benzathine penicillin, 2.4 million units, 1 week after the initial dose. So the purpose of this per CDC is to avoid that vertical transmission, not only treat the patient, but to avoid vertical transmission. However, if the diagnosis is in the second half of the pregnancy, so VDR positive, at 28 weeks, the management should also include a sonographic and fetal evaluation for congenital syphilis, because if we go in, if the patient is diagnosed on VDRL and then we see high drops or severe growth restriction, that fetus is probably going to need, as we pointed out earlier, that fetus will probably need treatment after birth. So what are those signs? Fetal or placental syphilis, hepatomegaly. We can actually see hepatomegaly. We can definitely see ascites, high drops, which is edema in more than one place. So high drop, pleural effusion, pericardial effusion, subcutaneous edema. Fetal anemia, which we wouldn't know unless we measure we can measure the risk of fetal anemia by measuring the blood flow in the brain of the fetus, or a thickened placenta. So placenta is usually 3 to 4 centimeters thick in the third trimester. Anything more than that is suspect for placentomegaly, and one of the reasons is syphilis. So those are the findings that we look for on ultrasound. And we see these findings, then this fetus will definitely require treatment after delivery. And then when we're treating our patients in labor and delivery, or I'm sorry, in pregnancy, because of the breakdown of the treponema that can occur as a result of treatment with penicillin, this can lead to what's called the Jarisch-Herxheimer reaction, which is just a fancy name, which we wouldn't use the eponyms, but basically when that happens, it causes an immune response with fever, chills, and contractions, and can actually lead to preterm delivery. So I've only seen this happen once, and it wasn't as severe as a preterm birth, but I'm sure some of you have already lived through this kind of situation. My biggest challenge in pregnancy with patients who are penicillin allergic is, because penicillin is the only acceptable treatment for syphilis in pregnancy, anybody who's penicillin allergic needs to be desensitized, and that person has to be desensitized before each dose. So if a patient is going to get 2 or 3 doses of penicillin, desensitization prior to the dose of penicillin has to occur prior to each dose. So patients usually come in, and we usually work with our colleagues in infectious disease or allergy, and we gradually desensitize. And that just means giving minute doses of penicillin, building up until we exhaust the immune response in that individual, so that when we give them the whole bolus of benzathine penicillin, the 2.4 million units, by then they can't mount that allergic reaction that can be associated with penicillin therapy. So for late latent syphilis, we recommend 7.2 million doses, which is 3 doses of 2.5 million at 1 week interval. So these are the guidelines based on the CDC in 2021. And so you can see there's a slight increase in the dosing based on the fact that we're not only trying to treat the individual, but we're also trying to prevent vertical transmission. Some of the other caveats of treating syphilis in pregnancy, and I'm almost done here, are that syphilis is diagnosed and treated at or before 20 weeks. Serological titers should not be repeated before 8 weeks after treatment. There's no point in treating them. But most women, as opposed to what we often see in the literature, most women will not have a 4-fold decrease in titers before delivery. That does not mean this is a treatment failure. It just takes a while for that immune response to cool down after treatment. So even when we've been told that we treat them and then we should test them afterwards, we won't always see that 4-fold decrease, but that doesn't necessarily mean that the treatment hasn't been successful in preventing vertical transmission. However, if there is a 4-fold increase in titer, and this is important, after treatment, 1 to 8, 1 to 8 up to 1 to 32, and if that increase is sustained for more than 2 weeks, that is concerning for treatment failure or for reinfection. So at the very least, there should be stabilization. There can be a slight increase or slight decrease, but seeing a 4-fold increase is concerning, and not seeing a 4-fold decrease doesn't mean failure of treatment. So when is treatment considered inadequate? If delivery occurs less than 30 days after treatment, or there are clinical signs present at the time of delivery, or the maternal antibody titer is 4-fold higher than the pre-treatment levels. As I was saying, there are no alternatives to penicillin. If the patient is on a 2 or 3 dose schedule, if a dose was missed and more than 9 days have elapsed between doses, that's not acceptable, and patient has to restart treatment for their syphilis to prevent vertical transmission. If a pregnant woman misses any dose, they should repeat the full course of therapy. And as I was saying earlier, treatment of syphilis during pregnancy is estimated to reduce the risk of congenital syphilis by 97%, stillbirth by 82%, preterm birth by 64%, and neonatal mortality by 80%. So why isn't it 100%? Well, these numbers have to do a lot of when treatment was started, how late it was between the diagnosis and treatment. As I was saying, once that fetus hits that 18 to 20 week mark, the immune response triggered by the fetus will start to cause damage in the fetus. So if treatment started or diagnosis and treatment began much later after that occurred, then the later we wait, the more damage we're going to find in the fetus. And as Dr. Foster pointed out, if infection occurs in the first or second trimester, virtually more than 80% of fetuses will be infected and suffer consequences of their disease. So this is, I'm not going to do this. We've already looked at this. This has to do with the 2 and 3 doses that we use for different stages of syphilis. This is just showing contrasting treatment between non-pregnant and pregnant individuals. And I'm just showing that actually for late and tertiary, 3 doses are recommended, even in the non-pregnant population, but definitely 2 and 3 doses of the pregnant population. There is no 1 dose for a pregnant woman. And these are some of the resources I want to put out there. They're going to be in the slide set, so you will have access. You don't have to memorize any of this stuff. And this is just a really nice picture I took recently. This is actually a city, Machu Picchu up in the Andes. It's fascinating because Machu Picchu was probably built in the year 1400 and something. And when the Spaniards came to Peru, when Francisco Pizarro came to Peru, and they took Cusco, which was the center of the Incan Empire, nobody said anything about Machu Picchu, and they never found it. And it was overgrown by vegetation and not really found again formally found in the early 1900s. In the 1910, 1911 ones was when the first archaeologists went in to do formal excavations and determine. So for 400 years, this place was kind of hidden under the vegetation. The only people who knew about it were the locals. And it just came to my mind because I was thinking of syphilis. And there's just a lot we still try to understand about the immune response, about creating a vaccine, about how we can prevent congenital syphilis. But we don't have to go that far to try to decrease the frequency of this condition in our setting, in our practices, in our community, in our state. Simply implementing early screening, early diagnosis, trying to find ways to help those individuals who cannot access prenatal care in a timely fashion are the best ways we can go in there and tackle this situation. So thank you very much.
Thank you so much, Dr. Contag. I really liked that last bit about Machu Picchu. I appreciate your time and being able to hop on such a busy day. In the interest of time, there is a, Dr. Contag, if you can check out the Q&A box while Dr. Douglas is presenting, we do have one question for you. But other than that, we will move over to Dr. Douglas. Thank you again so much, Dr. Contag. And I will have Dr. Douglas take it away.
All right, everyone, can you hear me?
Yep.
You can see my screen?
Yes.
Okay, great. So good afternoon, everyone. Thank you so much for having me. My name is Alexandra Douglas. I use she, her pronouns. I'm an attending physician in the Generalist Division of Obstetrics and Gynecology and Women's Health at Montefiore Medical Center, and I lead our substance use and disorders in pregnancy program. I'm thrilled to be presenting here in Minnesota because, as I was telling folks earlier, I actually went to school at Macalester, and so Minnesota has a dear place in my heart. I'm going to be presenting on caring for pregnant persons with substance use disorders, shifting from criminalization to chronic disease management. While this is a little bit of a shift from talking about syphilis in pregnancy and congenital syphilis, it is important to talk about these two topics together, as substance use is often comorbid with sexually transmitted infections. And the fear of criminalization because of substance use in pregnancy can lead to delayed access and care, and therefore screening and recognition of sexually transmitted infections. Okay. Financial disclosures, I will say that I'm going to be mentioning some off-label uses of medications as they are used in addiction medicine, and I'm going to highlight these medications as such. I also will be highlighting some of the challenges faced by prenatal care providers between evidence-based practice and state laws, and the opinions I express are my own and do not represent guidance from the Minnesota Department of Health. So our objectives today are as follows. First, to understand through example how racial and moral constructs have historically and into the present day shaped medical diagnoses of substance use disorders, especially in pregnancy. Then I'm going to provide a brief overview of the scope and the impact of substance use disorders in pregnancy, and then shift to a review of evidence-based management on specific disorders through the lens of chronic disease management. We will then review key issues faced by pregnant persons with substance use disorders when navigating pregnancy and care systems. And finally, we're going to look at how to provide appropriate referrals for these patients. So focusing on our first goal, I'm just going to ask you to think, who has ever heard of the words a crack baby, a drug baby, a cocaine kid? And I just want you to think about some of the images that come to mind. When you look at the images in your head, do you notice, is there a racial association, a class association? Do you think of like urban versus rural areas? And do you have any thoughts or ideas about like what the long-term outcomes or abilities of these children are? And so where do these ideas come from? When we look back at data from the 1980s and the 1990s and through to today, what you see is that the rates of drug use as well as the rates of drug sales are almost identical between races. In fact, if anything, use is higher among white people. However, when we look at the rates of drug-related criminal legal measures, Black people are about 6.5 times more likely to be criminalized or incarcerated for drug-related crimes. And if you look at the data specifically for pregnancy-related drug criminalization, Black pregnant women are almost 10 times more likely than white women to be charged with drug-related crimes. And when we look at the history of this, there is a very long history of family regulation and separation within the legal system. This goes back to slavery and taking children away from enslaved parents, a pattern which was perpetuated into segregation and then into the drug wars and into the ongoing industrialized criminalization of Black people in this country. Harriet Washington, who's the author of the book Medical Apartheid, documents in her book how the history of medicine is intertwined with racist ideology and shows how medicine is made up of, quote, medical myths. Academics may know that these myths are not factually true, but they are so grounded in the thoughts and values of our culture that they have become academic medicine. And in her chapter on the drug war, she exposes how in 1985, there was a New England Journal of Medicine article published by Dr. Ira Chasnoff, which described babies born to cocaine-using mothers as smaller, moodier, sicker, and less social than their counterparts. Dr. Chasnoff himself was very clear to cite the limitations of this study, that there were only 23 infants involved and there was no control group. But it sparked this entire cultural phenomena based on the findings of this study. And if you look at news articles and the role that the news played in how we began to respond within the medical field, you see a plethora of articles like what we see here. The Washington Post warned that an inner city crack epidemic is now giving birth to the newest horror, a bio underclass, a generation of physically damaged cocaine babies whose biological inferiority is stamped at birth. And I think it's very clear here that inner city is describing urban, poor Black populations, and that we're then assigning an underclass and biological inferiority with explicit racism. But this is very different from what evidence-based medicine actually tells us. Yes, cocaine crosses the placenta and the fetal blood-brain barrier. Vasoconstriction is the major purported mechanism of placental impact, and there is likely an association between cocaine use, preterm birth, and low birth weight. But the applicability of most of the studies that we have on cocaine use in pregnancy are limited by major methodological findings, such as failure to account for maternal age, parity, socioeconomic status, or other substance use, particularly alcohol or tobacco. And most of what has been perpetuated by this myth, the fact that a baby can be born addicted to crack and cocaine, that children exposed to crack or cocaine in utero have lower IQs, or that there is a difference between perinatal exposure to crack and cocaine, have been completely debunked. But the impact of this myth has persisted. And if you look at any major news outlet throughout this time, you see the same thing: drug orphans, parents who can't say no. For the pregnant addict, crack comes first, crack's smallest, costliest victims, a time bomb, and cocaine babies. There are these major headlines that ask, can the children be saved? And this created the idea that a single episode of substance use was equal to a substance use disorder, which was equivalent to bad parenting, and therefore these individuals were criminals. In 2018, the New York Times editorial board actually published an apology stating that news organizations shouldered much of the blame for the moral panic that cast mothers with crack addiction as irretrievably depraved and the worst enemies of their children. They demonized Black women addicts by wrongly reporting that they were giving birth to a generation of neurologically damaged children. The myth of the crack baby, crafted from equal parts bad science and racist stereotypes, was debunked by the turn of the early 2000s, but by then it had been written into social policy and into legal code. And we still see this today within hospital policy. The 1980s and the crack epidemic led to a policy of test and report. This means that we as doctors should test pregnant women who had scant prenatal care, a history of drug use, placental abruption, IUFD, and other behavior suspicious for drug use, and report them to Child Protective Services if the urine toxicology is pregnant. But what you can see is that behavior suspicious for drug use could lead to all sorts of implicit bias, and policies such as scant prenatal care do not take into account the many barriers that people face when accessing healthcare systems. And yet, even as I stand here and give this presentation, this is the active policy at most hospitals across the country. At my own institution, we know that from our own data that this leads to racist practices. This study was performed at Montefiore in the early 2000s, and it showed that performing urine toxicology screening under these policies resulted in Black women and their newborns being tested 1.5 times more frequently than their white counterparts, even though the positivity rates were equal. And a current retrospective review is showing that these trends have persisted almost 20 years later. So where does this lead us? We have to recognize that as OBGYNs and pregnancy care providers, that we have been complicit in perpetuating a war on drugs and the separation regulation of Black and Brown families. As Dr. Jamila Parrott, the president and CEO of Physicians for Reproductive Rights, said, the notion that medical providers are unbiased and objective, practicing within a profession free of the legacies of racism, genocide, and white supremacy is fictitious. This ahistorical view has caused tremendous harm. Visits to the OBGYN to seek pregnancy care or for delivery can be entry points into the criminal legal system for parents and into state custody for children. Unless you think that this is only something of the past, there are innumerable examples of this for women in the present day being criminally charged for substance use in pregnancy, such as Native woman Brittany Pula, who was just charged with manslaughter and 4 years in state prison for having cocaine in her system at the time of a second trimester loss. These myths are so ingrained into our systems and our policies that most providers are not even aware of evidence-based management of substance use disorders in pregnancy. Most of us lack knowledge of professional society recommendations. We misinterpret urine toxicology screening, and we do not understand the difference between toxicology screening and confirmatory test, and we don't understand our own legal requirements, all of which leads to over-reporting. But it also results in an inherent conflict between the healthcare provider and patient, because we cannot be both prenatal care providers and law enforcement agents. This leads to mutual mistrust, and it reifies systematic medical racism. So we're now going to shift to our second objective, and my goal is to provide a very brief overview of the scope of substance use in the United States, as well as use-specific management in pregnancy through the lens of chronic disease. So what is the scope of substance use in the US? This is from a national survey that's performed every year on people 12 years or older, and it shows that 60% of US nationals report using some substance, including alcohol or tobacco, within the last month. And if we narrow this just down to illicit substances, we see that about 20% of Americans report using an illicit substance over the last month. Of note, marijuana is included in this list because even though it's legal for recreational use in 15 states and for medicinal use in 30 states, at the federal level, it is still considered illicit. And so what do we take from this? Substance use is very common. And while substance use is very common and can result in a positive urine toxicology screen, substance use is different from a substance use disorder. A substance use disorder is really defined as the clinically significant functional impairment or distress as manifested by health problems, disability, failure to meet responsibilities at work, school, or home. And this translates into pregnancy. Substance use in pregnancy is also quite common. Pregnancy overall is considered a protective factor, but almost 20% of pregnant persons in 2018 and 2019 reported using some substance, including alcohol or tobacco, during their pregnancy. Of these, the majority of substances used were alcohol and tobacco, but about 5 to 6% of persons reported using an illicit substance. However, of all of the pregnant women who reported using substances, only about 15% met criteria for a substance use disorder. Now, substance use disorders do have a significant impact on pregnancy and postpartum. If we look at pregnancy-associated deaths, which are defined as deaths from all causes within 1 year of pregnancy, an estimated 4 to 10% of these deaths in the United States are due to substance use and unintentional overdose. This number is even higher in some areas. There have been studies in Maryland and Utah, which show that as many as 24 to 38% of pregnancy-associated deaths have been associated with overdose. And to give a comparison that people may be more familiar with, both postpartum hemorrhage and preeclampsia account for about 8 to 10% of pregnancy-associated deaths. When we've looked at this data in New York from 2018 to 2019, what we see is that mental health is accounting for the largest portion of pregnancy-associated mortality in New York City, and that overdose is accounting for over 75% of these deaths, which makes overdose alone one of the leading causes of maternal mortality. While the final data is pending, it does seem like this percentage is rising in the 2019-2020 data. Alina Kranek from the Minnesota Maternal Mortality Review Committee was kind enough to share their 2017-2018 data. And while the numbers are much smaller and so it can be harder to make associations, the trend also appears to be consistent with about 12.5% of maternal like pregnancy-associated mortality being associated with overdose. The contributing factors of this are many. One is that postpartum physiology and the fact that tolerance has often been changed throughout pregnancy and the postpartum period. And so the risk of overdose is just much higher. We also know that the postpartum period is a high risk for depression, and that access to postpartum support and therapy can be very challenging for patients. In addition, postpartum patients face the demands of newborn care, child welfare loss, insurance change or loss in the postpartum period, inaccessible treatment programs for parents, especially who need to bring newborns with them, lack of prioritization in the postpartum period, and clinician lack of knowledge of treatment continuation, as well as discrimination in pregnancy and postpartum. I like to highlight that there are studies showing that the risk of overdose is higher in parents who choose adoption due to grief over the loss of a child, and among children, parents who have chosen termination, often because they're not offered treatment at the time of termination. There was also this study that was done out of Canada, which showed that removal of a child from the home increased rates of overdose by 55%. And that there is an emerging body of evidence demonstrating a link between child custody loss grief and maternal morbidity and mortality. This study showed that this risk further increased if the mother identified as indigenous or from another marginalized community. But what it comes down to is that the postpartum period can be destabilizing for patients with substance use disorders, particularly when combined with the family regulation system and child custody loss. And it's also important to note that most of these deaths occurred among persons who had unrecognized or untreated substance use disorders. And among those deaths that have been investigated by maternal mortality review committees across the country, most of these persons had contact with the healthcare system and with their obstetricians right before their death, which means that there were likely missed opportunities for intervention and prevention. And the Minnesota Maternal Mortality Review Committee specifically highlights the need for improvement in referral networks to improve outcomes for birthing people. So I'm now going to shift over to a review of the evidence-based management of individual substances during pregnancy. I'm going to go quite quickly through this section for time because it's probably the easiest to look up. The February 2022 edition of the Green Journal has an excellent clinical expert series on what OBGYNs and pregnancy care providers should know about substance use disorders in pregnancy. And so this can be great to refer back to. So how do we manage substance use disorder in pregnancy? Sorry, I skipped over a slide. Yes, first and foremost, abstaining from substance use in pregnancy and lactation is going to be the safest option. However, it can be extraordinarily hard to do so, and it is not the only treatment option. In fact, abstinence can increase risk to the pregnancy due to the risk of return to use. Return to use does not mean that treatment has failed. It just means that treatment needs to be modified. And it's important to remember that the abrupt abstinence from certain substances can be dangerous and even life-threatening. I think it's helpful to think about substance use disorders as the management of chronic disease. We know from managing chronic diseases in pregnancy that it requires changing deeply rooted behaviors. And we know that relapse in chronic disease management is common. If you think about pregnant patients you see with chronic hypertension, asthma, diabetes, and if you think about patients who have episodes of worsening chronic hypertension, either to not taking their medications or physiologic changes in pregnancy, think about worsening asthma exacerbations due to pregnancy or because they could not access their meds. Substance use is no different. And I find this table very helpful because it provides a visual of the rates of relapse between substance use disorders and other chronic diseases. And what we see is that the rate of return to use with substance use disorder is actually significantly lower. So now on to the individual substances. Alcohol is a legal substance with about 10% of pregnant persons reporting use of alcohol in pregnancy. It is significantly associated with increased rates of miscarriage and childbirth and causes fetal alcohol spectrum disorder, which is one of the leading modifiable causes of intellectual disability and development disorders in the United States. It is unclear how much alcohol is safe or unsafe in pregnancy. Not everyone who drinks has a child with fetal alcohol spectrum disorder, but even low levels of alcohol have been associated with FASD. And this is why ACOG recommends against any alcohol use in pregnancy. How the important thing to remember is that abrupt cessation of alcohol can be very dangerous, and that a patient who is alcohol dependent and trying to cut back or abstain in pregnancy should be referred for inpatient management. There are 3 FDA-approved medications for the treatment of alcohol use disorder, but none of these have been evaluated in pregnancy. Most likely they are all safe, but we have limited data on the use of naltrexone. We have some limited data on the use of naltrexone for opioid use disorder in pregnancy, and have experience with other similar classes of medication in pregnancy, such as disulfiram and acamprosate. But as with anything, you have to weigh the risk of untreated alcohol use disorder in pregnancy with the possible risk of these medications. In terms of benzos, historically, there has been concern because of an association of cleft lip or cleft palate, but most prospective studies have failed to report this finding. Some studies have showed increased risk of low birth weight, but others have not. There is evidence that prolonged in utero exposure can lead to neonatal abstinence syndrome similar to opioids, but it is treatable if it's appropriately monitored. And there have been no long-term effects on childhood cognitive development or intelligence. However, like alcohol, abrupt cessation of benzodiazepines can be very dangerous and requires inpatient managements with a taper. And there are no notable fetal effects and no additional fetal surveillance is required. Tobacco is probably the most common substance that is used in pregnancy, and it's reported by 10 to 12% of all pregnant persons. And probably has the most pregnancy-associated morbidity. Tobacco increases the risk of ectopic pregnancy and significantly increases the risk of stillbirth, PPROM, preterm birth, fetal growth restriction, and placental abruption. It does have significant post-birth effects with doubling the risk of sudden infant death syndrome, and it may be associated with attention deficit disorders in children and increased rates of infection and breathing problems. And while I think that this is the area that we're probably the most familiar with, behavioral intervention is the mainstay of treatment in pregnancy. Data for nicotine replacement or other pharmacologic aids is fairly limited and should only be performed after a detailed discussion of the risk and benefits of smoking in pregnancy. But in general, nicotine replacement is probably safer than smoking because of the particular harms of smoke itself. But some studies have shown no improvement in perinatal outcomes. Bupropion and varenicline have not been studied specifically in pregnancy, but they do not appear to have any specific teratogenicity. And it is recommended due to the significant placental effects that pregnant persons with significant smoking in pregnancy be monitored with growth ultrasounds every 4 to 6 weeks. The evidence for cannabis use in pregnancy is very conflicting and unclear. Some studies, and especially some newer studies, have showed increased rates of preterm birth, but they were unable to control for other confounding factors. There have been concerns about the neurodevelopmental impacts, but a 2020 systematic review showed that children with cannabis exposure largely fell within the normal range, though there have been some more recent studies that are calling this into question again. But Given the unknown effects, ACOG still recommends against any cannabis use. And you should also be aware that the newer synthetic cannabinoids may have effects on hypertension and respiratory distress, but the perinatal effects are currently limited to just case reports. But in general, if a patient presents with cannabis use, we should explore if patients are using it to treat nausea, pain, or anxiety, as it has often been perceived that cannabis is safer or more natural than other pharmacologic agents. And if so, we should be working with these patients to provide alternative management options. There are no FDA-approved medications for treatment of cannabis use disorder, but there are also no additional fetal surveillance interventions that are required. We're now going to transition to opioid use disorder, and opioid use disorder probably has the largest amount of data given the current opioid epidemic. It's important to recognize that opioid use has no associated birth defects. Untreated opioid use disorder has been associated with placental abruption, preterm labor, fetal death, and overdose, mostly because of overdose in the parent, leading to possible hypoxemia or death in the fetus. But the risk of opioid use disorder in pregnancy is largely due to the baby experiencing neonatal abstinence syndrome and opioid withdrawal, which is treatable when recognized. And overall, the long-term effects of children born to parents with opioid use disorder appear similar to children born who had no prior exposure. When you identify a patient with opioid use disorder, historically it was believed that patients needed to withdraw from opioids. However, we do have very effective treatments for the management of opioid use disorder, and it is no longer recommended that patients undergo detox or medically supervised withdrawal in pregnancy. And in fact, the risk of overdose significantly increases in these settings due to the lack of tolerance. So there are 3 FDA-approved medications for the treatment of opioid use disorders: methadone, buprenorphine, and naltrexone. Only 2 have significant evidence in pregnancy: methadone and buprenorphine. However, there are much smaller studies that demonstrate the safe use of naltrexone. Their mechanisms are different, and they are regulated differently by the DEA, which can impact patients' experience with treatment. Methadone is a full opioid agonist, and it is a long-acting medication, and so it has a very long effect, but it's a Schedule II drug, and so it must be dispensed through outpatient treatment programs, or OTPs, and you're required to participate in counseling. This can be very onerous on patients, especially during pregnancy, because when beginning treatment for methadone, you have to physically pick up your meds every single day, and even after prolonged treatment, you are still limited to just a 14-day supply of your methadone treatment. In contrast, buprenorphine is a partial mu opioid receptor agonist with very high affinity for the receptor. It's a Schedule III DEA medication, and therefore can be prescribed in the outpatient setting and dispensed by a community pharmacy. While you have to have the ability to refer your patients for counseling, it is not required in order to receive the medication. Patients do need to be in mild withdrawal to start buprenorphine, which can be a limiting factor. Naltrexone is a mu receptor agonist, and it binds and blocks the opioid receptor, and it blocks the euphoric effects of opioids, and so it therefore decreases cravings. It is not a controlled substance. However, there's more limited data in pregnancy. All of these medications have been shown to reduce all-cause mortality and to decrease illicit opioid use, increase retention and treatment, and decrease criminal legal involvement. With regards to pregnancy, historically, our treatments were limited to just methadone. However, the MOTHER trial was the first randomized controlled trial comparing methadone to buprenorphine. And what we saw in this study, which is shown on the graph up to the right, is that buprenorphine results in lower rates of morphine for neonatal abstinence syndrome, shorter duration of NAS, and shorter hospital stays. 3 subsequent multi-center RCTs have shown no difference in maternal and neonatal outcomes. Both are safe. Buprenorphine may be associated with fewer adverse effects for the mother. It's important to recognize that pregnant patients with opioid use disorder should be referred. In New York State, pregnant patients get priority access for opioid treatment and will be able to skip any wait list for treatment programs. My understanding is that in Minnesota, there are some targeted programs for pregnant patients, but they don't get priority access to general programs. At my program and institution, any patient who we believe requires inpatient stabilization at any gestational age, we refer for inpatient management on our antepartum service. And I would establish you to establish your own protocols with your antepartum units. Otherwise, at our institution, if our patients desire to start treatment with buprenorphine and they're under 24 weeks, they're likely a candidate for outpatient induction of buprenorphine. But if they're over 24 weeks, we typically refer for inpatient induction on antepartum. One of the most important things in terms of caring for a patient with opioid use disorder is providing anticipatory guidance. It is very, very common for patients to experience increased withdrawal symptoms and cravings, even if they've previously been stable on their methadone or buprenorphine dose for years. This is normal and it's common in pregnancy due to physiologic changes, but it can cause patients great anxiety if they're not prepared for it. Often patients are going to need their dosing split or to have their doses increased throughout their pregnancy, and patients should be counseled that this can be rapidly down titrated after their delivery. Pregnant patients and their loved ones should receive naltrexone during their pregnancy if they have an opioid use disorder, because the risk of overdose is increased in pregnancy and postpartum, again, due to these physiologic changes in their body weight as well as their body mass that affect their tolerance. And while historically there were concerns that withdrawal that this could precipitate things like preterm labor, it's actually the fetal hypoxemia and the risk of fetal death that is far outweighs the risk than precipitous withdrawal. And again, given that there's no really notable fetal effect, no additional fetal surveillance is required in pregnancy. So finally, coming back to stimulants, which is what I started our presentation with today, as we discussed, the data shows that stimulants such as cocaine decrease blood flow to the placenta, which can increase blood pressures and risk of preeclampsia, seizures, myocardial infarction, stroke, and pulmonary edema. There's also a known increased risk of PPROM, and it may cause fetal growth restriction or low birth weight, but the data is not clear and it's likely confounded because of comorbid smoking and diet. Additionally, while classically there has been association with placental abruption, the evidence is actually fairly poor and likely doesn't control for confounding factors such as smoking, and the absolute risk is still quite low. There is no evidence of a stimulant withdrawal in neonates, and long-term exposure for children who are long-term outcomes of children exposed to stimulants in utero are similar compared to children who are not exposed. There are no FDA-approved medications for the treatment of stimulant use disorders. Many medications are being trialed and are frequently used off-label. Multiple studies have been done on the use of antidepressants, which appear to have no real effect. There's modest improvements in periods of abstinence with buprenorphine, topiramate, and psychostimulants, but this is still off-label use. What we should always remember is that beta blockade is contraindicated after cocaine use because it can lead to unopposed alpha adrenergic stimulation leading to vasospasm. So if you have concerns that a patient may have recently used cocaine, you should avoid using labetalol in the setting of acute hypertension. However, it's often asked whether this is a medical indication for urine toxicology in pregnancy. And it's important to recognize that most of the time you would need to make these clinical decisions before you would ever have the results of a urine toxicology screen back. And so if you're concerned, you should just avoid labetalol from the get-go, and a toxicology screen is not necessarily indicated for this decision alone. Due to time, I'm not going to spend a lot of time over these next couple of slides. In general, what you should know about breast or chest feeding is that you should familiarize yourself with the varying time it takes for each substance to leave the body and pump and dump for those periods. ACOG does formally recommend against breastfeeding with cannabis use. However, some data suggests that it's likely still safer to breast and chest feed and smoke than to formula feed and smoke. The one notable exception is for patients who are in treatment for opioid use disorder. Breastfeeding is encouraged if a mom is on methadone or buprenorphine, as it significantly reduces the rates of neonatal abstinence syndrome and opioid withdrawal syndrome. Breastfeeding should still be avoided if there's use of heroin or other unregulated opioids. So I'm now going to move on to our third objective, to review key issues faced by pregnant persons with substance use disorders when navigating care systems. I personally think that this is probably the most important section of my talk today. In the first part, we reviewed how bad science and racist media led to substance use disorders and pregnancy being criminalized. We then reviewed how evidence shows that while substance use disorders have significant impacts on maternal morbidity and mortality, especially when combined with the family regulation system and child custody loss, that most substances apart from alcohol and tobacco have no long-term fetal or neonatal effects when they are appropriately managed. And substance use disorders can have huge impacts on the family unit, but that most data shows that family separation has a greater impact on childhood development and maternal health. So this section is really going to talk about where the key places that we as providers can help mitigate a massive amount of harm. So how do we identify patients with a substance use disorder? If we look at ACOG or other professional society recommendations, they state that screening based only off of factors such as poor adherence to prenatal care or adverse pregnancy outcomes is going to lead to missed cases of substance use disorders, as well as lead to stereotyping and stigma. Therefore, ACOG recommends that it is essential that screening be universal, however, that it be performed with a validated verbal tool. And it is important to note that ACOG recognizes that a positive biochemical test or a urine toxicology test is not in and of itself a screening test or a diagnostic test for substance use disorders or its severity. ACOG recognizes that urine toxicology screens do not screen for alcohol or tobacco, which, as we mentioned, have the greatest fetal impact. In addition, urine toxicology screens have the potential for a ton of false positive and false negative results, and that there are varying lab cutoffs for sensitivity. Most pregnancy care providers do not use urine toxicology screenings appropriately, as a positive test actually requires a confirmatory test to be done. And when I've given this talk to OBs, I've often asked how many providers have ever sent a confirmatory test after a UTOX. And the majority have said no, because they don't know what the confirmation test requires. And if you look here, this is just an example of how that algorithm ever works, and most people have never even seen it. But in addition, the use of urine toxicology screening, due to the historic and present day legacy of test and report, leads to increased risk of child welfare involvement, which increases the risk of adverse outcomes for both the child and the neonate. And even though there is no association between a positive test result and parenting capabilities, a positive urine toxicology screen has been used by the state as the basis for a child removal in almost half of removals of children under the age of 1 month old. And it is often applied selectively and in a racist fashion. So ACOG recommends universal screening with a verbal tool. And I'm going to go into what this may look like in areas where there's mandated reporting. But there are multiple validated screening tools in pregnancy, such as the NIDA Quick Screen, the integrated 5 Ps, a substance use risk profile pregnancy scale, and the 4 Ps plus. I personally use the NIDA Quick Screen, especially just because it's a single question that you can use for each of alcohol, tobacco, prescribed medications for their use of illicit drugs. You just ask, in the past year, how often have you used the following? And if someone answers yes to any of these questions, you then use the NIDA modified screening tool. This additional screening looks at a lifetime use of any substance, use of any substance over the last 3 months, how often you've had a strong desire or a craving to use these substances, and how often it's led to health, social, or financial or legal problems. And you can see that this is a very different sort of screen than a urine toxicology, which has a high chance of a false positive because maybe this person has a substance in their system versus is this patient's use of a substance actually impacting their life and their ability to meet their functional needs. What I also like about the NIDA modified screen is that it provides a risk assessment to give you an idea about how high of risk their current substance use is, which correlates to the DSM-5 guidelines for diagnosis of a substance use disorder. And so when we talk about urine toxicology screening and how it should actually be used, evidence-based management or evidence-based use of a urine toxicology screen is really limited to the therapeutic monitoring for addiction-based treatment. And that's it. So if somebody is in treatment, to monitor their adherence to their prescribed medications. It is not recommended during pregnancy, peri, or postpartum, or in the newborn, unless it's medically indicated. And I've tried to look at what are medically indicated uses outside of addiction treatment, and I have never found a clear definition. It is likely left vague so that providers can decide for themselves if it's needed. But as we discussed in the setting of cocaine, most clinical decisions can be made and will be made without the results of a urine toxicology screen. And a urine toxicology screen itself is not a confirmatory test. But if it is used, all major professional societies from ACOG to the American Society of Addiction Medicine state that informed consent must be obtained by the patient or the parent and must include the medical indication of the test, the ramifications of a positive screen, and the right to refusal. And so one of the most important things that we need to know when we're caring for patients with substance use disorders is what is the legal landscape where we are working. The laws around substance use disorders and pregnancy vary vastly by state. Even within one state, varying providers and agencies are going to interpret laws differently. And it's important to recognize that in some states, the laws are so severe around substance use disorder that it is actually recommended to consult with a lawyer before disclosing substance use to your pregnancy care provider. At the federal level, in 2016, an amendment to the Federal Comprehensive Addiction and Recovery Act, CARA, added new preventions to the Child Abuse Prevention and Treatment Act, CAPTA, which from now on I will just refer to as CAPTA-CARA, to support newborns and their caregivers that are affected by substance use. This amendment reiterates that substance use alone is not an indicator of child abuse, maltreatment, or neglect. It does require states to perform data collection on the number of substance-affected newborns by hospitals and requires hospitals to develop what they call plans of safe care, which if people have questions about, we can get into during the Q&A. The idea is that this is a tool to support families impacted by substance use with the goal to ensure that families are receiving comprehensive support, care, and treatment to meet their needs. However, as with many things in this country, it has been left to each state to develop its own guidelines for implementation, and it looks very, very different. When I give this talk in New York State, this is my summary slide. Substance use in pregnancy is not a crime in New York State, and it is not legally considered child abuse. A person cannot be involuntarily committed for substance use during their pregnancy, and healthcare workers are not mandated to report substance use in pregnancy, delivery, or postpartum to Child Protective Services. Healthcare providers are not required to perform urine toxicology screening on a pregnant, birthing, or postpartum person. However, this is very different in Minnesota. In Minnesota, substance use in pregnancy falls under mandated reporting laws. Historically, Minnesota has had some of the most punitive laws in the country, but in 2021, a new statute was passed which exempts prenatal care providers from mandated reporting so long as the patient remains in prenatal care. However, if a patient misses a prenatal care appointment and the provider has tried to reach out to them, and they aren't able to reach them and the patient does not report to care, they're still required to report within 72 hours. In Minnesota, substance use is considered child abuse, and it can be grounds for civil commitment. And the state also requires toxicology screening if substance use is suspected. As mentioned earlier, there are targeted programs for pregnant persons with substance use disorders. However, pregnant people are not given priority access to general programs, and pregnant people are not protected from discrimination or stigma in publicly funded programs. So this can leave providers in a very conflicted place, given the discrepancy between evidence-based care and state requirements. Because what we know is that prenatal care does improve birth outcomes, but disclosure of a substance use disorder is a personal choice, and patients may have reasons for not disclosing their substance use, especially when we consider there are many reasons why patients may miss their prenatal care appointments, and therefore this would become a mandated reporting situation. However, when it is disclosed, it does allow for referrals to treatment, coordination of care, and the development of plans of safe care. However, even with the statutory exception for prenatal care providers, we do need to counsel patients that if you have developed a therapeutic relationship with your patient, the doctor delivering the patient is not always their pregnancy care provider. And what is often challenging, and this is true in New York as well as Minnesota and the rest of the country, is that any member of the care team can make a report to the state. That can be a doctor, a nurse, social worker, pediatrician, etc. And even if the doctor or other care members do not want to report made because they feel like the patient is engaging in treatment and care and they do not suspect child abuse, if that report is made, once the report is made, it is out there. And a prenatal care provider may then legally be required to answer questions and disclose any discussion about the patient's substance use. And these investigations can be very, very invasive into patients' lives. With or without your permission, state officials may begin to speak to your family, friends, healthcare providers, asking about you and your parenting abilities. These questions can be broad and intrusive. Often there are blanket requests for medical and mental health records and surveillance in medical and mental health services. Officials can drop into your home at literally any time for an unannounced visit. And if there's suspicion for an unsafe home, the child is removed from the home and a court case is opened. A conditional plan may be developed, which includes parenting classes, entering treatment programs, frequent check-ins and home visits. And if you do not comply, this can also result in an open court case, which often requires obtaining an attorney and legal phase. And if your child is out of the home for 15 to 22 months, your parental rights may be terminated. And so you can imagine how much this can disrupt a parent's ability to go to work, to keep a job, or to seek treatment, which leads to a compounding system favoring family regulation and separation over keeping families together. And as we discussed, child custody loss increases the risk of return to use and overdose. But it also has a significant impact on the child, as there's data showing that removing children from the family of origin and placing them outside the home has been associated with negative developmental consequences. And so we have to begin to change the experience of pregnant persons with substance use disorders in our care. And one of the ways that we can do this is just in our words and how we approach patients. There have been studies on patients with substance use disorders that show that stigma, bias, and discrimination experienced by patients from their providers, particularly their OBs, negatively impact their ability to receive high quality prenatal care. And it is our job to emphasize that substance use disorders are chronic diseases that can be effectively treated. And when we tailor our care to patients' specific needs, they have higher retention rates, reductions in substance use, and fewer barriers to care. And as I'm sure you know, our words matter. We can change our language. For instance, instead of using words like a pregnant addict, a user, a junkie, we can instead say a pregnant person with a substance use disorder. Instead of a drug baby, we can say an infant with signs of withdrawal. And because these words do not define a person by their substance use and shows that a person can manage their disease. I'm now just going to move on to our last objective. And so, but I do want to just quickly point out 2 points about non-judgmental and supportive care. First, I'd just like to add that the decision to carry a pregnancy to term is a very personal decision, and it is common to have conflicting emotions. It is important that we tell patients who are using medications for the treatment of substance use and or using alcohol and other drugs that it should never be a reason that a patient needs to have an abortion if she otherwise does not want one. However, as we discussed, there is an increased risk of overdose following termination. And so if a patient opts for termination, we do need to make sure that we're still offering referrals for treatment. Similarly, early pregnancy loss is extraordinarily common, as you can see here, and substance use should never be blamed for the cause of a pregnancy loss. We should be providing reassurance and support. And so now on to that last goal to discuss what appropriate referrals are. The exact protocols are going to differ by institution, but caring for pregnant persons with substance use disorders requires a multidisciplinary approach. At most institutions, we tend to be very siloed, but providing coordinated care for pregnant persons with appropriate anticipatory guidance is extremely important for harm reduction. These teams should include the pregnancy care provider, a substance use treatment provider, the neonatologist, the anesthesiologist, lactation consultants, and it may also include lactation consultants or social community health workers. I personally recommend that we be tailoring the frequency of prenatal visits to each person's individual needs. I often find that patients that are new to treatment may need to be seen every week or every 2 weeks as they initiate treatment, even though many patients in long-term treatment will be very comfortable with our standard prenatal templates. We also need to make sure that we are obtaining active verbal consent even to perform verbal screening. So what I mean by this is that, especially in a state with mandated reporting, that we are informing patients that of the risk and benefits of telling us that they use substances. We say, I would now like to ask you some questions about some substance use. I do need to inform you that in Minnesota, it is considered mandated reporting. However, if you're actively engaged in your prenatal care, I would not have to report you to Child Protective Services. However, if you missed an appointment, I may have to report you. This can result in the opening of an ACS case. And then we give people the option to report to us, understanding both the benefits of reporting for access to treatment, but also the risk. We also need to ask for verbal consent to develop plans of safe care, as well as for coordination of care. And again, we should actually be providing written informed consent for urine toxicology screening, given the association with family regulation. But it's important that we're providing anticipatory counseling about what patients will experience, because even if they're in treatment, they may have increased cravings and their medications may need to be adjusted. And we do need to be working very closely with substance use providers to find the optimal dosing for patients in pregnancy. We must also make sure that patients understand the legal landscape around substance use wherever they're living, and that they understand their rights. I personally, at my first visit with patients, will give patients a list of access to free legal resources and free legal counsel. And lastly, we need to explore patients' goals for the pregnancy. We need to be talking about what are their goals for pain management and set reasonable expectations and offer anesthesia consults. If the patient is using a substance with a significant neonatal withdrawal syndrome or that has fetal effects, I would recommend a consult with a neonatologist to talk about anticipatory guidance about workup and hospital stays. And then we can also talk about patients' breastfeeding goals and the recommendation by substance. Because the postpartum period is so destabilizing for patients, especially when combined with family regulation and child custody loss, we do recommend that the first postpartum visit happen within 2 to 3 weeks. If the patient has an opioid use disorder and has required a cesarean, I actually recommend even sooner follow-up within 2 to 3 days to follow up on pain management. And then ongoing postpartum care should continue until at least 12 weeks postpartum, typically at 6 and 12 weeks. But then I would encourage a warm handoff to their primary care doctor and their treatment program. Ideally, this transition becomes seamless in order to avoid lapse in care, which increases the morbidity and mortality in the postpartum period. And so with that, I would just this was a program that I learned about that I did want to make you all aware about. Project Child is a program that's offered in Hennepin County for patients that are still under 34 weeks, where they can be referred, that really is using a harm reduction approach to try and minimize the impact of referral to child services. And so I've included the website here, and it would be very worthwhile reaching out to them to learn more about their program. And so lastly, these are our recommendations. Just because of time, I'm going to leave it at that so that I can answer any questions.
All right, thank you so much, Dr. Douglas. I don't see any questions in the Q&A box right now. And I didn't see any come through the chat. So I will, I'll look at the puppy. I will monitor that while I do my conclusion slides. And at the very end, if there's anything left, we can touch on that. So anyone with questions, please feel free to pop them in the box. All right, I am going to, we have Dr. Contag saying thank you. I'm going to share my slides again. All right, and there's not much to report because this was the last day of the syphilis learning series this month. So we are at the end. So I appreciate you all who came to any of the days, taking time out to learn more about syphilis, as it is an ongoing issue that we see in the state of Minnesota. Like I mentioned earlier in the day, we are providing an evaluation when you close out of the Zoom window. The link will be there, and then we will also email it. So please do fill that out because we do put on educational activities like this a lot, and your feedback is very helpful as audience members. But other than that, thank you so much once again for attending. This is my contact information down here. If you have any questions, any follow-up, you need linkages to any of our speakers throughout the past 4 weeks. And I appreciate you all coming. And I will stop there. Thanks, everyone.